evening. We welcome you all to the STEP program, the Star Teachers in Plastic Surgery, the Next Generation, the new web series. The motto of this program is to learn, to contribute, and to encourage. So, welcome to the episode 9 of season 1 of the STEP program. We have one session today, a talk on liposuction, principles and practice, and the speaker is Dr. Sasikumar Muthu, who has finished his MCH plastic surgery from Chengalpattu Medical College from 2007 to 2010. He has been a resident at Ganga Hospital, Coimbatore, an assistant professor at Plastic Surgery Department at SRM Medical College, Potteri in Chennai, and then founded the Pearl Clinic, a multi-specialty clinic at Chennai in 2013. His fields of interest are aesthetic surgery, breast reconstruction surgeries, hand reconstructive surgery, hand injury management, burns and diabetic foot management. And the moderator for this session will be Dr. Ashish Davalbhakta, who is the professor and head of the Department of Aesthetic and Plastic Surgery at the Aesthetics MediSpa Pune, which is an MUHS accredited aesthetic plastic surgery Fellowship Center. He has been the APSI Visiting Professor in Aesthetic Plastic Surgery in 2018 and the Educational Representative for the ISAPS EC for Asia. Dr. Ashish has been a consultant at the South Manchester University Trust Hospital at Manchester, UK, and done fellowships in plastic surgery from St. Andrews Hospital and Addenbrooke's Hospital in UK. He has done his MCH in plastic surgery from the TNMC Nair Hospital, Mumbai. Over to you, Dr. Ashish sir.
Good evening. Good evening. Thanks, Dr. Karthikeyan. Thank you very much. It's really an honor to be invited here to moderate your fantastic teaching program. I really like this concept where you get a junior plastic surgeon to come forward and present, which gives him confidence, and he gets a peer review. He learns in the process, and he also instills confidence in his juniors that it's not that difficult to achieve that step. It's really a privilege to have been invited to moderate this. Dr. Sasi is a good friend of mine. I know him since many years, and we keep on meeting at all these conferences. I would love to hear him speak, and I'm sure there'll be lots to learn from him. And we will have this as an interactive session and more like a discussion. So over to Sasi. Let's hear you on your talk.
Thank you.
You can start sharing your screen, Sasikumar.
Yeah, sure. Is it okay, sir?
Yeah,
Can
okay.
Start?
Yeah. It's good.
Yeah. Good evening, all, and it's a great privilege for me to be talking in front of all my professors and well-wishers here, and I'm so happy. The topic given to me today, GK sir, thank you so much. And topic given to me today is liposuction, principles and my practice. And since 2013, I have been doing some aesthetic work, and gradually I've been increasing my volume. And I thought, when GK sir asked, I can speak about liposuction more confidently. As we all know, most commonly done cosmetic surgery worldwide is liposuction. It looks very simple, and it is like, for any beginner, it might look like one other aesthetic surgery, but it is more challenging, more so challenging for a beginner, because few things, selecting a patient or giving the result is a key factor here. And both the times we as beginners have been facing a lot of hardships. And I thought I'll share few principles and how I practice my liposuction assets. And we always aim to give a very safe and consistent result when it comes to liposuction. Then why is this presentation? See, liposuction is truly a revolutionary surgical advance, but it is often a victim of disappointment created by unrealistically high expectations by the patient side and an inappropriate patient selection from the practitioner side. Basically, the people who start liposuction early, we feel like we should do liposuction on everyone who comes and asks for liposuction. We end up in giving a very not so happy result, and we try to lose confidence on ourselves about the liposuction as a procedure. To break these things, There are few key principles which are present and practiced all over the world when it comes to liposuction. That is regarding 1, patient selection; 2, the technique of choice; 3, monitoring the patient preoperatively, intraoperatively, and postoperatively, and safely performing a liposuction procedure and giving the desired result to the patient. These are the 5 key principles what everyone aims at when we choose a liposuction as a procedure. So what is generally followed? I have divided this presentation into 2, what the general principles are, and the next half will be how I have put in practice. So when it comes to patient selection as such, a well-informed patient with realistic expectation is the key as for any cosmetic surgery. Whenever a patient walks in with expecting excessive weight loss or a body shape of some other person, they bring a photo, can you make me as slim as this? Be a little careful in choosing those patients. Next, give adequate time during the consultation, because this is not like a hand injury or a burn where we can immediately say this is the solution, you need to go for it. Here, we need to assess whether the patient is in a healthy body, having a healthy body and a healthy mind. Unless we give adequate time during the consultation, it is very tough to come to a conclusion whether this person is a good candidate for a liposuction. Then, patient within the ideal weight range. Generally, I avoid liposuctions above BMI of above 30. A person within the ideal weight range, 10% above and below the ideal weight, is a good candidate for a liposuction. Then when it comes to physical examination, few things you have to be watchful. 1, the exact amount of fat that's easily assessed by skin fold thickness. Next is elasticity of the skin, the quality of the skin, whether there are multiple striations and stretch marks and the scars in the skin and any undulations and depressions, zone of adherence, wherein we see like some part of the skin will be adherent to the underlying muscle. So we need to assess all those things in physical examination in addition to the underlying muscle strength in certain areas. If you are doing abdomen liposuction, we have to be very sure the underlying recti is strong, there are no herniations. The thorough clinical examination has to be performed like any other procedure, then you subject for a procedure. Consent. See, this is the key thing in an aesthetic practice. Before even you give a consent form to the patient, you should have explained every single detail about the procedure, about the recovery, what kind of follow-up patient has to come to us, and the complications what he or she can face during the procedure and how we manage it, and the cost involved. Everything, if we can explain concisely, then a consent form should be given to the patient and the attenders to go through it, then sign it. Never give a consent form, then ask them to sign and then expect them to be like really following you. So always make sure the consent form is given to them, explain to them in detail, then they subject to the procedure. Photography and marking. These are the key things in a cosmetic practice, and particularly liposuction. What I do is I try to take in the same background, and unfortunately I'm not able to the same dress what they're wearing. Sometimes they're saying, certain papers are saying, try them to ask them to come in a dress what they've worn during preoperative stage, so that the results are very easily comparable. But whatever said and done, a clear photograph of a preoperative stage, if needed, an intra picture, and a post-operative follow-up pictures are must. Then marking. I do a trial marking always in the patient even before they come for a theater, so that they will understand what kind of results they can achieve. When it comes to techniques, there are a lot of newer machines and equipments coming in. For example, laser, radio frequency assisted liposuction, the gold standard power assisted liposuction by Microair, ultrasound assisted liposuctions like Z-lipo, and suction assisted liposuction. That's the standard one. And the pioneer or the first one to come out was a syringe assisted liposuction. There are innumerable techniques available. But when I was working with Dr. Armugam sir, he used to say one single line: more than the mission, the surgeon behind us is the key for giving you a good transformation. So, irrespective of the mission, we need to be really following certain aspiration principles to give a better result. So, what is the key factor in liposuction? See, once you assess there is X amount of fat and you're going to aspirate that amount of fat preoperatively, there are two methods of tumescence. We use either wet or a super wet. Wet is like less than the aspirate. If you're like you have assessed that you roughly are going to aspirate a liter of fat, then you give tumescent which is less than a liter. that is called wet liposuction. If you're going to give equal amount of infusion, like tumescent infiltration, that is called as super wet technique. What we generally follow is a tumescent technique, where we almost give 2 to 3 times the aspirate volume. So we inject the tumescent fluid through the port, wait for the turgor, the skin, to just gently swell, and once you remove the cannula out, there should be a fountain of tumescent coming out. That is a good sign that you have adequately tumesified the area to be aspirated. Then cannula insertion or selection of the cannula. There are multiple type of cannula. If you're going for a large volume liposuction of more than 3 to 4 liters or 5 liters, use a bigger cannula initially in the deeper plane. Then as you move up, leaving 1 to 1.5 centimeter beneath the skin, use a very finer cannula like 3 or 2.5 mm cannula to feather out the fat. This will give a very smooth result. And more than the cannula selection, the technique of crisscrossing is key factor here. You are not supposed to aspirate in the same plane, in the same direction continuously. Then monitoring the patient. Most of the time what happens, we think liposuction is a simple process and we just start aspirating, but there is a constant fluid shift happening. So you have to monitor the urine output. If you are going to do a large volume liposuction, better to catheterize it. So never hesitate to catheterize. If you're going to aspirate more than 5 liters, catheterize the patient, monitor the urine output, be very safe when it comes to aspiration. The next thing is, there is a chance of pulmonary embolism. This is what I mentioned. In a consent also, we have to mention it and make sure patient understands it. It can happen, and if it happens, it can be easily managed by the anesthetist if detected. So if there is a drop in saturation, then immediately you can alert, take a break, tell the anesthetist there is a drop, should we proceed or can we give a positive pressure ventilation to make sure it is not going in for a grave issue. The next, safety. I always tell this, never rush through the procedure. Be very relaxed. If you have an outpatient on the day, but don't be in a hurry, just cancel it off. For you, that patient is the key factor on that day. Take adequate time, spend with the patient. Even during the surgery, a relaxed surgeon can give a better cosmetic outcome. Explain in detail about all the possible adverse effects that we have done already, and again do it before the procedure. Select the technique that you are comfortable with. As I mentioned already, multiple techniques might be there. Select what you are comfortable with and go ahead, master it, then move on to the next whatever technique you are trying to inculcate in your practice. And avoid large volume aspirations as far as possible. By large volume, the definition what ASPS has given us, more than 5 liters of fat aspirated in a single session is considered to be large volume. So never, as I already mentioned, this is not an emergency procedure. Give patient adequate time and also for recovery. So avoid large volume liposuction. By doing this, we can avoid untoward complications. And admit 34 hours large volume aspiration. These are the principles when it comes to safety of the patient. And the next thing is, in doubt, never hesitate to approach your colleague. One more brain is going to give you a better insight, and you can give a safe transformation to the patient. End of the day, the patient interest comes first. And results. So this is what happens when we are starting our practice. What we think, no, we think we have to convince the patient, and we might be tempted to give a false promise. Never do that. As a professional, explain what exactly a patient can expect out of this procedure. Tell them it is not a procedure for weight loss. It is only a procedure to shape up. So make all the other issues cleared up, and patients will come to you. You don't need to be in a hurry to convert a patient for surgery. And follow up regularly. That is the key factor. See, generally in our scenario, patients like disappear off of a radar after a certain time, but still you can get them back to you by sending a message and following up them regularly. Compression garment and all other post-operative protocols like avoiding strenuous activities for 6 weeks, everything has to be in a document. What I generally do is send a PDF document which has all these things so that patients can read well in advance before even coming for a surgery. And again, I'm stressing on photo documentations, because a lot of times we get into trouble if we don't have a proper photography of the patient. So what is my practice principles of, these are the key principles what are available, and how I put into practice is what's going to be the next half. So when it comes to patient selection, I don't operate on cosmetic surgery patients above, I mean, like below 18 years, specifically procedures like liposuction and other things, because they are not in a position to understand what the procedure is. And however you explain, I don't know how easily they can follow our post-operative instructions. So better a patient turns 18, wait for them to understand the procedure, then you can do the procedure anytime. Few instances like exclusions are there, like gynecomastia, where we operate at 15 or 16, we can do it. But still, by and large, 18 is the upper limit. And I have this practice of giving 2 to 3 weeks from the initial consult, the time to decide, 2 to 3 weeks from the initial consult to the day of surgery. This way, we are giving adequate time for the patient to understand the procedure in detail, knowing about all the complications and the follow-up. Then finally, they can decide whether really they need this procedure. If they need it, where they are going to get it done. So that way, a well-informed patient can make a better decision. And consult along with the parents if patient is unmarried, and with the spouse if married. I'm stressing here because in my first when I started doing liposuction in 2013 and all, a lot of like 2-3 patients. The patient was happy, patient's mother was happy, but the husband came from nowhere. Suddenly, like he pops in and he says, "No, I want my wife as she was looking beforehand, before the liposuction." So to avoid these issues, better to ask the patient whether you want to be consulted with the spouse. If yes, please bring him. We'll consult along with them. Then we'll give, this is what your wife or husband will look like after the surgery, and is it okay to go ahead? If there is no such issue, then you can directly, you can go ahead, and since it's a major, you can directly go to the procedure. And explain the flow of events in detail. Whenever they're coming for a consultation, give them what exactly liposuction means, what all we'll do, what technique we are going to do for you, what is the duration of surgery we expect to perform, and what is the recovery time, and how long it takes for you to recover and do day-to-day work, and then how long you have to wait till you take care of sternose activity, which is roughly around 6 weeks. So all these things we have to explain in addition to that, the cost. In cosmetic surgery, most of the time, the issue happens when there is a mismatch in the coat. So always try to give a appropriate coat, explain it in detail, give a breakup, so that patient understands that this is the cost he or she may he may undergo for pay for this procedure, and the GST which is involved for the cosmetic procedure. Everything, if you explain in detail, no patient will be like creating trouble later. Then the consent document, as I already mentioned, I have a habit of mailing the consent document well in advance, like 2 weeks after the first consult itself. I mail it off to the patient. I'll ask them to read. If there is any query, they can get back to the second consult. Then I ask them to sign in front of me, that stating that they have understood the procedure in detail. Then I also sign. Then we take them for the surgery. So this is just to make sure patient feels comfortable, like he or she has understood the whole procedure in detail. When it comes to the technique, my preferred technique, I feel syringe gives me a better control if it is going to be less than 1000 ml. A small volume liposuction, I generally prefer a syringe suction, because the vacuum created in a syringe is quite good, and we won't be aspirating too much in a single area. But if I'm going to do a larger volume liposuction, I prefer micro air power assisted liposuction. Leave alone the name, it's a power assisted liposuction, and it actually reduces the fatigue what we undergo. Otherwise, syringe is also a better technique. And when it comes to tumescent, I prefer either superwet or a tumescent liposuction, so that there is less bleeding and a good plane of dissection is achieved, and aspirate is quite clean. So more than injecting the tumescent, the time you wait between the injection of tumescent and starting of aspiration is the key. That's what I said. You have to be having adequate time. So never rush through the procedure. Give 20 minutes for the tumescent to act and break the fat by doing a pre-tunneling. Then you aspirate the fat. Otherwise, what happens? You might end up in a bloody aspirate. So that should not happen in a liposuction. Crisscrossing the cannula. See, if initially when I started doing liposuction out of enthusiasm, I used to do cannula movements in the same direction. But I finally found when the results came out, there was a small bands-like thing happening in the skin. So that's what I said. When in doubt, never hesitate to approach your teachers. So I asked Dr. Ramcharan sir, he said crisscross. Crisscross, even though it's given in books, we try to overlook sometimes. So he said never fail to crisscross. So what I did, then after following him, I started to crisscross. Then I found out the results were more smoother. So next is remove out and reinsert after every 10 pass if you use a power assisted liposuction, because since the fatigue is lost, you are tempted to keep on sucking the fat continuously because you don't feel the pain. No? So this might lead on to over aspiration in certain areas. So to avoid that, every 10 pass, when your cannula is being beneath the skin and you're guiding with the non-dominant hand, every 10 pass, take out the cannula, then again reinsert and aspirate. So this way you can avoid over aspiration. And whenever, whatever surgery you do, whatever technique you follow, try to get 2 to 3 syringes of fat stored in, harvested initially and stored separately, so that in case accidentally you over aspirate and there is a contour deformity, you can re-inject those fat into that area. But nowadays the canisters are also sterile, so if you have a sterile canister, it's well and good. Otherwise, I will suggest you can go on for a syringe liposuction for the first 500 to 600 ml. Keep it separately, let it decant, then you do a proper power assisted liposuction. If you feel there is some contour irregularities in certain areas, you can re-inject the fat and give a better result. When it comes to plan and monitoring, see, as we all know in plastic surgery, we need to have a proper plan, and same holds good for this liposuction also. Pre-operatively, what I do is I have a paper, I get on what all areas I'm going to do a liposuction. I ask the patient to come for a trial marking, show them, draw it in a paper and keep it always. And you have to stick to the plan. Never ever deviate, even if you feel it's going to benefit the patient, because the patient has consented for certain things and we are supposed to stop with it. So if you do a fat liposuction of the abdomen and flanks, that is the thing what they've consented to, discard the fat. Don't try to put it elsewhere thinking that he or she might feel happy. It is not going to happen. So better to stick to our plan, and what patient has consented for you pre-operatively is the final procedure what we are going to do on table. And keep a constant watch on the cannula movement. This is where we miss out. See, the cannulas are like long, and sometimes we use a very finer cannula, it can bend. So always make sure the cannula is well felt by your non-dominant hand, so that when you pass it beneath the skin, you don't go inadvertently enter into the muscle plane or a deeper plane. When you're going to the abdomen, you don't enter into the viscera. It has happened, but you can avoid by constantly watching for the cannula movement, and the tip has to be seen at the end of the cannula, skin. Color of the aspirate. Whoever is assisting, they might miss out. So as a surgeon, we can have the tubing running in front of us, so that when you do a lipoaspiration, stop your aspiration immediately. And values. So that's what I mentioned. You have to keep an eye on the monitor which is available on the anesthetist side, just to look at the SpO2 levels and pulse, heart rate, and blood pressure. Everything you keep a watch. There's nothing wrong in we also keeping a watch. It's like a double check. And ensuring the safety, I always admit a patient for a day. See, initially, I used to discharge on the same day, but sometimes late night they'll call, sir, I get up to pass to get to the restroom, I'm feeling a little giddy, I'm uncomfortable. So these things will make you undress. So better to admit a patient post liposuction for a day and discharge on the next day. Nothing wrong. The room rent might be additional, but they don't mind paying it. But you can have a better follow and perform a surgery in a facility with good intensive care unit, and an intensive care physician is there to handle any untoward issues happening post liposuction. Because patients post surgery, they might ask why you did here. So never compromise on the safety, and avoid combining too many areas and procedures along with liposuction. See, I used to do like whole body. I thought like, okay, we'll put on the prone, do a liposuction of the back, thighs, and upper back. Then again, put on the front and put abdomen, arm, and anterior thighs. But what I felt was doing multiple areas, two things happen. One, we are doing aspiration above the safe limit, and patients can end up in complications, more seroma collections, more bleeding, and sometimes we get fatigued a lot, and sometimes we might not give a better result. So better to choose certain areas which is critical, what patient has come for, do that, then ask patients to come for subsequent sessions for additional areas. And combining procedures with liposuction, except tummy tuck and gynecomastia, I generally avoid, and breast aug with fat fill, I avoid liposuction to be combined with other surgeries like breast reduction or arm lift or thigh lift. Try to avoid too many procedures at one session. This is to ensure safe recovery for the patient. And documenting results, how I do is I take care of pre and post results. I maintain a logbook. Since my PG days, I have a logbook. I keep writing it of each cases, what I do. And if there is any untoward complications, I mention it there because it helps me to revisit in future if needed and try to manage it effectively. And I never feel bad to document any unusual complications, whatever can be like skin necrosis or whatever. I try to record it as much as possible and explain the patient it is possible. And I discuss with my seniors and professors and get a learning how to avoid it. So as Ashish sir said, at any age, it doesn't stop my learning. I don't want to be like, okay, I know everything about liposuction, then the worst thing will happen. So I am not in that mode. So I thought anyone for that matter, and never get worried about complications. We have to face issues. We might have contour irregularities. We might have skin like puckering. So these things, everyone goes through it. So you just need to be confident, but the principles are the key. So when it comes to results, and this is a few results I'm going to show here, and I'll tell what I did and how I managed post-operatively. So this patient, primarily, she's like unmarried and she has a good abdominal wall, except for excess fat. And she came for liposuction. We did liposuction of the abdomen, flank, love handles, and the upper back. Then what I generally do post liposuction is I give 4 to 6 sessions of ultrasonic cavitation with RF skin tightening. This helps in improving the lymphatic drainage from the liposuction area so that edema gets down much earlier and the result of skin tightening is much better. And number of sessions is again depending on the patient choice. And again, this patient, we did I did a liposuction of roughly around 3,500 ml. So why I'm saying the last patient was just 3,000 ml, the next patient was 3,500. You don't need to do large volumes to give better results. So choose right patients in early stage, give them better outcomes. They'll be very happy. And I always combine ultrasonic cavitation with RF skin tightening for my post-operative follow-up patients. And gynecomastia, I don't do just with liposuction. I do liposuction, then I do a Webster to give a much contoured chest wall. And here I don't use this massaging techniques. I just tell them to wear a compression garment for 6 weeks and they're happy with the results. Arm lipo, again, it is the most sought after here because people feel uncomfortable. Here I just stick to the posterior aspect. For some people, they might require medial and lateral. Nothing wrong in aspirating, but make sure you don't go so deep into the plane. Medial, I try to avoid as much as possible because of the neurovascular bundles present there. And this patient had this was preoperatively itself. I have a consent form where I explained that you have already striae marks, your skin has lost the elasticity. So post-operatively, you might have a skin which might require additional procedures like tummy tuck if you want a flatter abdomen. Patient was happy with the result, but I was not comfortable. Even now, I'm just following it up, and he's not keen. He said, "I'm okay, sir. I've lost weight. I'm comfortable." But this has to be mentioned in the consent form to avoid any unwanted arguments post-operatively. Again, this patient this is not a six-pack. This is what I was mentioning. I was like over-aspirating in the anterior abdomen. It formed a band. Patient thought, okay, it looks like a six-pack, you can leave it, but it is not advisable. We should have much smoother contouring. So after this only, I started doing crisscrossing technique. This patient was very adamant. He wanted a liposuction. I said, you are not going to lose any amount of weight because your internal fat and muscle belly are much protuberant. Excessive subcutaneous fat is not that much to achieve contouring, but he was so vehemently asking for liposuction. I did it, but I decided not to operate anymore on such patients because he didn't create trouble, because this is not the principle what we follow. He is not a candidate for liposuction. So these are the mistakes which I did in early start of my career, and I stopped doing this, and I have gone in for strict patient selection protocols, so I'm able to achieve desirable result for the patient. So when it comes to closing remarks, this is just an overview. Within 20 minutes, I've tried to put what all I can put as a principles, what I learned and what I put into my practice. And each one, whoever is listening to this, whoever is watching this, can devise their own principles and make sure the principles are like generally accepted one, so that it will ensure a very safe transformation for the patient. And thank you again to GK sir and all the seniors who have been listening this. It's been a, like what to say, it's my privilege to present in front of all of you. And I expect to learn from you again during this discussion phase. Thank you so much, sir.
Thank you very much, Sasi. A wonderful presentation. I think you covered almost every important aspect of liposuction really well. I mean, right from the start to the end, I think there are a lot of pearls that others can pick up from what you have said. And I'll agree with most of them. There are only a few things that I would like to add. And then what we will do is we can have a discussion basically on on various aspects of liposuction. Then we can take questions from others. As you rightly said, I think it's a very simple procedure. It looks like a very simple procedure, but I think it is a very skilled procedure. And it is the man behind the machine. The machine doesn't matter. I mean, if you need to know what to leave behind, not what to take out. If you want to give a good result. Taking out is easy. If you just go in there and you suck everything, I mean, you can take out everything, but you will sometimes lose the curves. You can, not get an aesthetically good-looking appearance, and it all depends on the perception. And as the patients are getting more and more educated, more savvy, their expectations are going up as well. So, if we aim to deliver the best result possible that will satisfy ourselves, we are more likely to be able to make the patient happy too. So let's take each point of yours one by one. I think patient selection is the key. If you don't select your patient properly, you can land up in doing a wrong procedure and get a bad result. Patient selection will start from the time they inquire, and as you rightly said, that their expectation, what do they expect. So at that point, what I ask them whether they're looking for a spot reduction or are they looking for a body contouring. So you have to look at, you have to ask them what their BMI is, their height, their weight, all the things that you have rightly said. And usually these inquiries come digitally over the internet, over emails, or over the phone, and they may just want to know the price. But you have to kind of dig these things out from them over the email. You may want to ask them to send their photographs and see if they're right candidates who you can help. So first is you have to select, are they patients who you would be able to help? And the next thing is you want to find out what is their skin tone. The skin tone is most important. I tell my patients that once the fat is removed, they want to reduce their weight, so they say that remove my fat. But once the fat is removed, the skin needs to tighten, tone down, and get a good shape. So you have to be able to see whether they are suitable for the liposuction or are they more suitable for a tuck, a tummy tuck or a thigh lift or an arm lift or whatever. So let's say that they have come in for a consultation. So you would take their height, their weight, you would check their BMI. If you have a body composition analysis, you'll check the fat percentage. And to assess the skin elasticity, whether it is over the phone or digitally or in clinic, I have a few criteria. One is age. Obviously, with advancing age, the skin's elasticity is going to go down. BMI, the higher the BMI, the less chance that the skin will be elastic. But BMI is not the only criteria. I think high BMI people who have never lost weight could still have good skin elasticity. It is the weight loss. You ask them if they have lost weight or they have had multiple attempts of weight gaining and losing. If they have had that, then they are likely to lose their elasticity. And those who have lost weight by dieting, primarily they tend to lose the protein from their skin, because the essential protein requirement of the day is met through collagenylysis from the skin, and the skin loses its elasticity. And these are the people, if you liposuction them, the skin will just hang and they'll not be happy. Then look for stretch marks, you look for scars. If they have that on the tummy, then again the skin is not like to contract. Or if they have a pendulous skin fold. If they have a pendulous skin fold, then that means the skin has already given up on its tone and has become pendulous. The tone has gone. And a pendulous skin is more likely to stay pendulous, a deflated pendulous appearance after the liposuction is done. The last examination would be obviously the elasticity of the tone of the skin. You pull the tummy skin, or you feel the thigh skin or arm skin, and look for retractability. How quickly does it snap back? And that's the last, for examining, you would give you an idea whether they are suitable candidates for liposuction. So typically the young women before pregnancy would be obviously good candidates for liposuction. And after pregnancy, obviously after stretch marks and other things, you would want to recommend a lipoabdominoplasty for them. Another important point is to start small. I think for those who are young, I would recommend that they should start with small areas. It's better rather than taking these large overweight patients for liposuction. As Sasikumar said, focus on maybe gynecomastia, focus on the front of the tummy, and try to do those well, and you are likely to have happy patients. You gain your confidence, and then you move on. As I said, that I ask my patients whether they want a spot reduction or body contouring. At that point in time, you can, through your questions or history taking, you can try to ascertain what is in the mind of the patient, what kind of, mental image or requirement they have. If it's just spot reduction, then you can just treat those areas and they'll be happy. But often they are expecting a transformation. Or if you can do that, once your experiences increase, then you can offer all the other things that you have in your armamentarium. I mean, you can help them have a curvy figure, narrow the waist, and also think about fat grafting to the hip dips or to the buttock area to increase the curviness and attractiveness of the figure. The high definition, and then the 4D, where you are even adding fat to certain areas like the pec or the shoulder or whatever. These are things that would come once you have gained confidence with the basic liposuction technique. But you should explain these to the patient, like these things are also there, and let the patient take a choice of whether they want to go for them. And always think about starting small so that your confidence is improved. Technique wise, as Sasi said, that it's the man behind the machine. Which technique you use, it doesn't matter. All the techniques that are there, right from simple suction, syringe suction, to power assisted or ultrasound, is to make it easy for the operating surgeon to reduce the fatigue in the procedure. It's all still debatable. I mean, people do get very good results with just power assisted. But in my experience, I have felt that I have both the Vaser and the power assisted, and I feel that the definition is just a little bit more with ultrasonic device, and the smoothness and evenness is just a little bit better. The skin retraction that the ultrasonic devices claim is purely because of the thermal energy. Ultrasound is a high energy device. It's really hot at the tip of the probe, and you are creating a burn underneath. That's why all that fluid is required to keep it cool, and you have to be extremely careful. You need to know not only where your probe is, but you need to know the depth. And that's where, with experience, you will start judging where the tip of your cannula is, which depth you are in. And tendency is naturally is for the probe or cannula to go into the subscarpa plane. So I will want to explain to you the concept of deep fat and superficial fat. The deep fat is the one beneath the scarpa, and as one's weight starts going up, if you have more fat cells in particular area like a lipodystrophy, the deep fat tends to fill up first. But there is a class of patients who have a generalized obesity where they have fat almost everywhere, and in them what they have is increase in the thickness of the superficial fat as well. So you do need to reduce the superficial fat in them to get a substantial amount of reduction. And those who are regular gym goers, are exercising, are trying to lose weight but not succeeding, or trying to get look defined but not succeeding, these are the patients who have a little bit of deep but mostly superficial fat. And in them, if you go into the superficial plane and then remove the deep layer of the superficial plane, and for the sake of etching or to give definition, you just come into the middle plane. So you are now visualizing the superficial plane into three zones: the deep, the intermediate, and the superficial in the superficial plane. So the superficial layer you don't want to touch at all. The intermediate layer you only want to touch or liposuction when you want to do etching or definition, like you want to etch the midline or the lateral rectus or back or whatever. So the first attempt at liposuctioning has to be to obviously remove the deep fat. The moment you have made your opening open with a forceps or wherever, you tend to go into the subscarpa plane, you empty the deep. Keep an eye on the aspirate, because there's a tendency to keep going back again and again into the area that you've suctioned. So you feel like you're suctioning a lot, but in fact, there's hardly any aspirate. So you need to keep an eye on that, and you tend to over suction areas. And the moment you start coming superficial, then the aspirate starts getting bloody. So you have to have a three-dimensional understanding of where your cannula is and where you have suction. I think Sasikumar did cover the techniques, the tumors, the fluid infiltration fairly well. Yeah, I think 1:1 is fairly good. Super wet, which is called the super wet technique, the tumescent technique where you're using 2:1 is proposed by Klein, and it's more when you're doing it under local anesthesia. Otherwise, if you're doing it under some regional anesthesia or general anesthesia, you don't necessarily have to put in that much fluid. And when you're using a power assisted, or sorry, not a power, but an ultrasonic device, then the effectivity of the emulsification can reduce when you put in too much. So they recommend around 1:1. So one point about the aspiration is, where do you start? There are some there's a debate about whether you should start deep or middle or superficial. I prefer to start in the middle. You hold the skin fold up, pinch, and then go in the middle of the skin fold, because you then tend to have fat on either side. And then what kind of cannula are you using? If you are using a double Mercedes cannula, then it's going to suction from all the sides. So you stay in the middle, you start suctioning there, and always crisscross or continuously keep the cannula moving. No two strokes in one area, and have a feel of the tip. Try to keep the tip pointed up so that it is not towards the abdomen. All those things that Sashi has covered them really well. And then once you have finished, then use your left hand to press down, so that you are guiding your cannula tip and giving a shape with your left hand rather than the right. The right one, especially if you are right-handed dominant, then the right one is just going to move back and forth, and the left one is going to help in contouring. So if you want to narrow the waistline, or you want to push down with your left hand so that you start coming more superficial, and you are also sectioning the deep part too. So all these things are fairly fine. Regarding admission, whether to admit or not admit, I think Sasya has covered it well. It's always safer and better to admit the patient but if it's low volume, like as you said, if it's less than 5 liters, or I would say a few zones, like 3 or 4 zones, you're only doing the waistline, I don't admit. I treat them as a day surgery, and I restrict the total volume to less than 10% of the total body weight. There are some states in the US where 5 liters is considered to be the max. And yeah, you have to be very careful when you're using lignocaine in your infiltration. If it is only a tumescent technique like Klein advocates even up to 35 milligram per kilogram of lignocaine concentration, and he has a paper where he has even gone up to 55 milligram per kilogram. But when you're using a general anesthetic, if you're doing then I would suggest that you should try not to use lignocaine or stay very low, because there is an observation, some papers where the liver metabolism of lignocaine is hampered when a general anesthetic is given. So whether it's halothane, isoflurane, or whatever, DP, cytochrome 450, and all those things, they do affect the metabolism. So the clearance of lignocaine is delayed, and that's how you start getting lignocaine toxicity. So I prefer not to combine lignocaine when I'm giving a general anesthetic. And in regional anesthetic, I don't need it anyway. So I would use only lignocaine when I'm doing it like under conscious sedation or small local regional anesthesias. Yeah, so rest of the care and treatment is the same. Once you have achieved your result. About the drains, I prefer to drain. I give the patient an option to have an open drain or a closed drain. And I tell them that if they go for an open drain, then the dressing is likely to get soaked, and sometimes the clothes get messy. But a closed drain, like a Redivac or whatever, then fluid keeps collecting in there, maybe 2 to 3 days, and then you cut the tube short, let a couple of days of open drainage, and then they're dry. Now, there may be some seniors amongst you who probably don't drain or have a different drainage protocol, but when I use VESA or ultrasound, I find that drainage is a lot more, and it's better to drain them. And I think Alfred Hoyas and others also drain, and it just becomes less messy and convenient. And of course, for larger areas, if I'm doing, say, the complete waist and chest, side of the chest or whatever, arms as well, or thighs, then I admit the patient, keep the patient overnight, and they go into compression garment straight away. And after discharge, they keep coming for dressing. Massage is very important. The massage helps, and as Sasi said, you could use whatever, even cavitation technique, but it's massage. I mean, dermal stimulation or deep massage will help the lymphatics to wake up again and help the dermal swelling to go. They feel better as soon as they've had a massage, and they voluntarily keep coming back for massages. And it takes around 3 weeks for the swelling to reduce enough for them to start feeling better and see a good result, and 6 to 8 weeks for the final result. The skin may take time to contract, and that's why there are some who advocate a compression garment for even a longer duration. And you can ask them to wear even up to 3 months or 6 months, and the skin keeps on tightening. And as Sasi said, that radiofrequency helps in tightening this thin skin. So if you may not see a good result with the radiofrequency prior to liposuction, but after you've done the liposuction, then when the skin has thinned down, it tends to show immediate dramatic kind of a tightening. So there's a definite role for radiofrequency post liposuction in getting the skin to tighten. I think let's take a few questions? Anything that you wanted to discuss or talk about, Sasi, before we? Okay. Anything?
No, sir. I think we are.
Hmm.
I think we have time to hear from the seniors. No, they'll be able to give us some input.
Right. Okay. So yeah, some questions. We've got quite a few questions coming in, and I'll fire the questions to you. Let's hear the answers from you, your experience on them. What would you do if a patient has diabetes? I mean, what precautions you observe in pre, per, and post-op period?
Yeah, generally, diabetic patients, I make sure the glycemic control is quite good and HbA1c is within normal range. Otherwise, I don't operate large volume liposuction.
Okay.
Small areas I do treat, but large volumes I try to avoid as much as possible. That's what I have been doing.
Right. So I would look at the HbA1c. I'd see how well they are controlled, and if they're fairly well controlled, then I would do a liposuction, and they go back onto their anti-diabetic regime that they have had. There may be a period when the sugars may go up, and you may have to involve a diabetologist to manage them in the post-operative period. But I see no contraindication if the control is good. If they're obviously uncontrolled, then I wouldn't operate, as you rightly said. What precautions, Dr. Kanjur has asked, would you do in an abdominal liposuction, particularly anything?
Preoperatively, I make a proper clinical examination to rule out herniation and what is creating the bulge, whether it is like subcutaneous fat or the internal fat. How is the recti divarication which is creating the bulge? So patients generally say my abdomen is protuberant. They might think that it is a fat, whatever it is, but generally it can be sometimes the divarication which is creating the protuberance. So we need to clinical examination to rule out any kind of herniations and recti divarication. Then I do a CT imaging to confirm it. If there is no herniation, there is no recti divarication, if it is only going to be subcutaneous fat, I take them for liposuction. And precautions, I make sure the cannula is visible throughout the procedure, because the hair is the most complicating issue. Most of the time in abdomen only the risk happens. Entering into the peritoneum. So I make sure that the cannula is well visible, and that's it. I don't think any other precautions.
Can I just add something?
Yes, sir.
Please, sir. Yeah, sure.
Yeah, Sashi, it's good. That is abdomen lipo. You should be very careful. From my experience, or what you mentioned, rule out any hernia. Missed out hernia while doing a liposuction can create havoc. Second thing is the scan and the ultrasound scan or CT scan done for abdominal lipo is to rule out any intra-abdominal pathology. I had a patient whom I did the lipo. Post-operatively, he continued to have a protuberant abdomen. The CT showed some subepithelial or peritoneal tumor. So you should not miss out on intra-abdominal pathology. So I would request our juniors, before you attempt on abdominal lipo, try to do a good scan, either ultrasound or a CT, to rule out a hernia or any intra-abdominal pathology. Just I wanted to emphasize on this point.
Perfect. One point I would like to add to this is majority of males in India, usually they come for tummy, basically tummy reduction, and they have a very protuberant belly. We have to ascertain whether it is subcutaneous fat or whether it is intra-abdominal fat that is causing the bulge. One clinical test is to ask them to lie down flat on the clinical examination table and then see how much of the abdominal wall actually goes down, and check for the skin fold thickness there. If it is 2 or 3 inches and you feel that the abdominal wall is flat, then they are good candidates for liposuction. But if you feel that even after lying down, the abdominal wall is not going in, it's still protuberant, then they are candidates who you should advise weight reduction with diet and exercise. ask them to lose some weight and come back. Or you can get an MRI or an ultrasound and then try to distinguish where the location of the fat is. But if you liposuction a patient who has a lot of intra-abdominal fat, then he's not going to get a good result. He'll still be protuberant and he'll be unhappy. He will feel like he's kind of wasted a lot of money. The lower part of the abdominal wall is pendulous. If it's pendulous, then maybe you can empty it with liposuction. That may retract, but the rest doesn't. And yes, your ultrasound or clinical examination for hernias is very important. Let's go to the next question that we have. Dr. Kanjur wants to know what anesthesia would you prefer, regional, TIVA, or how do you go about it? What's your preferred anesthesia?
I always go for general anesthesia, sir.
Okay.
Except for very small area, I go for a regional. I don't know. Otherwise, I go for general anesthesia.
Right. Do you operate in a corporate setup in a hospital, or is it your own?
Yeah.
Okay.
No,
Corporate hospital. Okay. Yeah. Dr. Kanjur, sir. Yeah.
Yeah. Maybe Sashi, GA with all said and done good, but a good TIVA, that is total IV sedation, conscious sedation. You can do a procedure for, especially now the COVID days, you can avoid the GA. Say good IV sedation with a good tumescence, you can do for 2.5 hours, and the anxiety of intubation and extubation is not there. And the patient doesn't feel that there is no much of a hemodynamic changes in TIVA. So they experience a nice, good sleep. So I think you should try to follow this IV sedation. Convince your anesthetist to come forward to do that. Not all anesthetists can practice that TIVA. It saves a lot of anxieties on a surgeon. You can easily discharge. They just get up immediately after the procedure. No vomiting, no sore throat problems, and be very good. They should not hesitate to use all. My anesthetists use dexmedetomidine, propofol, fentanyl, preemptive anesthesia with paracetamol. So it's a combination of judicious combination of all medications. End result with no side effects like nausea, vomiting. My instruction or request to the anesthetist is my patient should not have any post-operative vomiting, no subconscious awareness. These two things are very important for our aesthetic patients. So I think you should try to follow TIVA. That saves a lot of anxieties on you.
Sure, sir.
Yeah. I absolutely agree with Dr. Kanjur, sir. That would be the way to go. I think conscious sedation through a TIVA does make it very easy. The recovery is good and safe. But your anesthetist need to be able to give it. I mean, I have struggled here in Pune to get my anesthetist to give IV sedation. Can I ask Dr. Kanjur, do you have a target controlled syringe pump, or are your anesthetist able to do it through any standard syringe pump?
I don't have the target control, but my anesthetist plays with the syringe pump. Yeah.
Right. Oh, brilliant. I mean, I've been trying to. I have a syringe pump, but my anesthetist can't do it. I mean, they just put propofol in a IV, drip, and that's their TIVA, which is not the right TIVA.
That's not right.
Anyway. There's a question whether we can do large areas under local anesthesia. And what's your opinion, Stacey?
Now, large areas I don't do under local anesthesia because few things like complications of large volume liposuction, like pulmonary embolism and all, if it happens, not local, we can't pick it up. Better to be safe with the general anesthesia. And large areas, we can't keep infiltrating that much of local. And the moment your cannula crosses those planes, it is going to create a lot of pain. Better to be under safe and positioning the patient. Large volume, like again, if multiple position is required, better under GA. I feel GA is much safer for large volume liposuction.
Absolutely, I agree with you. And on that point, that local anesthesia, even if you give, it tends to stay in a particular area.
Yeah.
And then you are hesitant to go to the edge because the patient feels pain, and then you're not doing a good job, and you kind of undercorrect the patient. So if it's a small area, it's fine. Dr. Kanjur has asked what's the opinion on drains, whether to leave it open or close them. What do you do?
I generally close the port wounds except the dependent ones. The few dependent ones I leave it open to drain.
Right.
But as you mentioned, people get more anxious when they see the dressing getting soaked a lot and messy discharge. So I started placing vario drains nowadays, like suction drains for 2-3 days in large volume liposuction. Small areas I just close and leave it. That's it. I don't place the drain at all.
Yeah. So gynecomastia doesn't need drains at all, and I've never seen any collection in gyneco. There are some areas that they don't need that much drainage, but lower abdomen tends to need a lot of drainage. And as a seroma formation too. I mean, I don't know how much seromas you have encountered, but with VASA we tend to see more seroma incidents. What about you, Dr. Kanjur? I mean, what's your incidence of seroma?
To tell you, I have not had any seroma after my liposuction.
Okay.
Maybe that is the one point which I wanted to insist on youngsters. The technique of liposuction should be a tunneling rather than cavitation.
Correct.
And I leave my straps open. It drains. So it may one day, exactly 24 hours, it may drain and it may be sodden and the field is moist and everything. But it takes away, maybe that is what I believe. I didn't have any seroma touchwood so far.
Okay.
Ashish, you have a question from Karthikeyan sir. Yeah, what do you feel is different in practice of liposuction in India when compared to practice in UK?
Right. Okay. So I was in UK between 97 and 2000. Sorry, I couldn't hear you. You finished your question?
We can hear you.
Right. Yeah. So I was between 97 and 2005, and mostly in the National Health Service. So in the National Health Service, there was hardly any cosmetic work being done, except for maybe tummy tucks and breast work and maybe some rhinoplasties. But liposuction work, one had to go with the consultant and work with him in private practice. And at that time, it was standard saline assisted liposuction that we would see. And Douglas Harrison and others who I have assisted at, the techniques were same. It's just that we are now using more technologies, and Alfredo Hoyos and all his concepts of superficial and deep and how to control the overall result, and plus the fat grafting. So we have now developed a lot. I don't think they do much in the National Health Service. And even in the private, they are a lot more conservative than, in fact, we sometimes are over here. There's
one more question.
Yeah.
Ashish, for you.
Yeah.
If you use a drain, what is the method of compression? And when do you apply the compression garment?
Compression garments go straight on the table as soon as the procedure is over. It's a standard compression garment. I import my compression garments from Isabella. And they are breathable, antimicrobial kind of compression garments whose elasticity will last the whole 6 weeks. Because I put drains, they don't get stained or soaked. They should not be too tight, obviously, because you want to have the lymphatics functioning. You don't want to compress the lymphatics too much. So just enough to keep the skin, just pressed down. You should be able to put the finger underneath. And the drains come out underneath the compression garment out into the drainage. So I prefer to put them straight on. You don't remove the compression garment for a couple of days.
And what is the role of protocol for VT prophylaxis, thromboembolysis prophylaxis, and large volume liposuction or combined lipoabdominoplasty? When do you start? I generally give previous day, start from a day before the surgery. We start with low molecular weight heparin and continue for 3 days post-operatively. Or sometimes I give a SCD devices continuously on. It starts from the day of surgery. It continues for next 2-3 days, and that's it. What is your take on it, Ashish?
I prefer on the other, DVT preventing techniques like compression stockings or a DVT pump,
Device, yeah.
and during the procedure, and get the patient mobilized quickly afterwards. Don't do very obese patients, and also limit the areas. I tend to break the procedure into stages. I prefer to do below the waist up to the knee in one procedure, and then if required, I'll do the upper back and arms or face or whatever in another. So either 2 or 3 stages, I'll break it so that the whole procedure is not too long and the patient is not in a compression garment like head to toe. So that's what I don't give any DVT prophylaxis as such because of the risk of oozing and bleeding. And Carlos Roxo also feels the same.
Okay. Thank you. Thank you,
So,
Ashish. I think that's the questions. We are done with the questions.
yeah. So now regarding the decision whether to go for the liposuction which you do when you're doing an abdominoplasty, I think that those are cases where you can still do upper abdominal liposuction. You can do the flanks and you can do the lower back. You can suction the fat, store it in sterile containers, and inject a little in the buttock, all at the same time. And the results are fairly good. You can use any technique, whether it's power assisted or Vaser. It doesn't matter. The fat that you aspirate does survive. And as you rightly said, you can keep some fat stored in syringes if you're doing syringe liposuction, and it's right advice to inject wherever you feel that you're over suctioned. So yeah, I think that covers this up fairly well. I think you did a great job in presenting the the topic. Is there anything else? Any other questions?
Thanks, Karthi and Sir.
So if you feel we can finish the session, sir, we'll wind up. Dr. Raj.
Yeah, sure.
Yeah, it was great. It was a great session today. I mean, liposuction, as you said, appears quite simple, but there are so many nuances to it. And I think Dr. Sasikumar, as you said, has done a good job today. I mean, he was very practical points he was telling from
Absolutely.
the beginning. And yeah, his practice.
Thank you, sir. Thank you so much, sir.
Yeah.
And when he started, what he thought of it and what he did. And then what you have beautifully added on to the points there with your experience in it. Thank you so much, sir. We had a great session today. And this session, this entire program is about introducing the new teachers. And I think we have another new teacher on the horizon.
Yes, absolutely.
And he has been heralded by you, one of the superstars here in this thing. So it's great. It was great having you here. Thank you, Sasikumar. Thank you, Dr.
Thank you so much, sir. Thank you.
Thanks you to all the participants.
Thank you.
And thank you to all
Thank you, Rai, sir. Thank you, sir.
Thank you.
Thank you, sir. Good night. Good night.